This session will be recorded and will be available after the event. If you have questions, please go ahead and place them in the Q&A box located within your console. We will have time at the end of the webinar to go through many, if not all, of your questions. If there's any questions that we're unable to get to, we encourage you to reach out to us at our Steps Forward inbox. That's stepsforward@ama-assn.org. As a disclaimer, AMA Steps Forward content is provided for informational purposes only, is believed to be current and accurate at the time of posting, and is not intended as and should not be construed to be legal, financial, medical, or consulting advice. Okay, without further ado, let's go ahead and get started with today's webinar. Today, we are lucky to have Kara Cappellucci-Ing with us. Kara currently leads the American Medical Association's Practice Transformation Portfolio, where she consults with health systems from all around the country to provide meaningful data to support practice interventions that promote physician well-being. Prior to joining the AMA, Kara helped develop and launch the National Academy of Medicine's National Action Collaborative on Clinician Well-Being and Resilience, a consortium of more than 200 organizations committed to reducing clinician burnout and suicide. Kara received her Bachelor of Sciences in Dietetics from the University of Maryland. Today, she will be presenting Fostering Clinician Well-Being, Current Trends and Insights from the AMA's 2022 National Report. Welcome, Kara. Thank you again for being here with us today. I'm going to go ahead and pass things off to you.
Great. Thanks, Brittany, and good afternoon to all of you. I'm excited to be with you today to share some of the work that AMA has been doing over the last several years as it relates to measuring burnout within health systems, but with a particular focus on our most recent national benchmark report, which will look at about 2 years worth of data. So just a brief agenda on your screen now for today's presentation. I'll talk a little bit about the background of our work, in particular the organizational biopsy, which is the assessment tool that we use within the AMA and with health systems with whom we collaborate. And then I'll dive into the report and share some high-level findings that we've had over the last 2 years of data with a final conclusion about some solutions and actions that we've seen health systems taking in the last year or two with a focus on our recognition program, which really provides a system-level roadmap for health systems. So we'll have time at the end for questions, as Brittany noted, so please put any of them in the Q&A box. Just as a bit of background on our work at the AMA around assessment, we have been doing health system assessments for a number of years now, going on 4 years. And so we work with any health system that desires to have a data-informed strategy around their well-being work. And we have worked with over 200 health systems during that period. Our work really centers on being the bench strength for health systems who want to measure. So we do the legwork on collecting the data, but also being a supportive resource to health systems in reporting that data and analyzing that data to better understand where there are high risk or high yield opportunities within that. And in addition, we support health systems in the what's next after they have data. So we certainly don't want to just say, here's your problem, but we also help guide systems to solutions and really long-term and short-term solutions depending on what we find in their data. This is mission work for the AMA. We feel really honored to be able to do this as mission work. So there's no cost to doing this work. And if you are an organization who is interested in assessing well-being holistically within your organization, we'd love to work with you, and there'll be some information at the end of this presentation on how you can do that. A quick note on our assessment tool. We refer to this as our organizational biopsy, and this includes the assessment tool itself as well as a set of services that we provide as part of that process. And as I alluded to in the previous slide, we are there both to help collect data and to help health systems decide on what questions are most important for them to answer within their assessment, but also to analyze those data. And we provide an online reporting dashboard so that health systems feel fully equipped to review their data in depth, as in-depth as they'd like to, and to use that dashboard to further stratify their results and dig deeper, as we like to say. Currently, our assessment is for physicians and APPs, so nurse practitioners and physician assistants. We are considering plans to expand this in future years, later this year, to nursing staff and others. We did complete an assessment or make an assessment available throughout COVID. This was our Coping with COVID-19 for Caregivers survey. This particular assessment was available to all role types. So this is something that we're considering expanding for our organizational biopsy as well. The organizational biopsy itself measures across several different domains, which you're seeing on your screen here. First and foremost, it includes the validated Mini-Z burnout assessment, which likely many of you are familiar with. This is a validated tool that really measures both burnout as well as the drivers within the system of burnout. We also have a domain around organizational culture. So this particular domain will look at things like leadership, both immediate leaders of respondents as well as executive leadership within an organization, and how that may be impacting organizational well-being, as well as things like trust and teamwork. There is a second domain that we consider our practice efficiency domain, and this specifically asks questions around team structure and team function, workflows, and how are workflows working, who's in those workflows, as well as stability of the team and the organization overall. Lastly, or second to last, we have a domain around self-care, and this is where we are exploring questions around post-traumatic stress disorder, which has become really important for organizations to think about measuring post-COVID and as we emerge from the pandemic or continue to deal with the pandemic. But equally important is post-traumatic growth. So we know that stress can, of course, lead to post-traumatic stress disorder, but we also know it can lead to really growth and thriving, and having organizations measure that has been really insightful for us. And then lastly, we have a domain around retention or career plans of respondents. And this has been extremely important in the last 6 months to a year. I think everyone has heard about the Great Resignation. We are certainly seeing in our data issues around staffing across healthcare. So that's no surprise to any of us, but these particular questions around work intentions and whether individuals feel that they will be reducing their work hours within the next 12 months or in leaving the organization altogether in the next 2 years can really help organizations plan for or also mitigate the impact of those changes. And so why measure? Most of you with us today likely don't need to be convinced of this, but we always like to start here. Why is it so important that organizations measure well-being and continue to track that across time? We certainly believe at the AMA that measurement of burnout is a core, it's a foundational strategy, and that most organizations who are committed to doing this work need to be using data to inform their decisions. I will note that in most organizations who had measurement and strategies in place before COVID have seemed to fare better than those that did not. So we measure for a few different reasons. To firstly identify and assess the underlying drivers of burnout within your organization. Of course, we know from research that drivers of burnout tend to be similar across organizations. However, critical to understand what's happening within your particular organization. You have your own unique cultures, own issues arising out of the pandemic, and with other happenings in your areas. So we think it's important to know this specifically for your organization. Once you do know this information, it will equip you and your leaders to reduce these drivers of stress, find those pebbles in your shoe or underlying areas that would be ripe for solution, and to really understand your organization's unique needs to support professional well-being. And lastly, this is really to help proactively initiate institutional support. We work with a variety of organizations. Some organizations come to us with a lot of infrastructure already in place. Perhaps there's a established well-being committee and a chief wellness officer, and there really is leadership support already and resourcing behind that support. But a lot of organizations that we work with, measurement is the first step in getting that buy-in from leadership to say, hey, we have a problem, but we also have solutions that we can look towards based on the data that we have. And we are happy to work with organizations to develop that messaging for their leadership and to really be a sort of a neutral arbiter of the data to help you in those conversations. So that's just a little bit of background about our assessment work and kind of where we've been and where we might be going in the future. And I'll now pivot into our actual national benchmark. So our national benchmark is 2 years worth of data. We keep it at 2 years worth of data, and this is updated annually. So the benchmark that we'll be looking at today includes responses from January of 2020 through the end of December in 2021. Any repeat organizations are removed, and we only use their most recent assessment. In the data set we'll be looking at today, there were approximately 104 surveys from just under 100 institutions. 3 of those surveys were pre-pandemic, which we defined as prior to March 15th, 2020. And we're looking at about 11,000 responses today from our physicians and our APPs. And again, this is a convenient sample. So organizations, we work hand in hand with organizations to actually develop the survey and choose the questions that are in their survey. Not every single survey looks the same. The main component that is included in every single survey is the Mini-Z burnout assessment, but demographics may differ by survey, and organizations may lean into certain domains more than others. So before I dive into the findings of those data in our benchmarking report, just a quick note on some demographics so you understand who is making up this sample that we're looking at today. For gender, our sample is about 40% male and almost 50% female. We do have a very small percentage of respondents that prefer not to answer. And a quick note on the prefer not to answer, this is actually an interesting trend that we've been seeing where prefer not to answer in our surveys is growing. Over time, it seems like a lot more individuals are preferring not to answer on a variety of demographic questions. Our hypothesis for this is that people are suffering right now. People are burnt out. They're very stressed. They are unhappy in their organizations in a lot of situations, and feel that these are really sensitive data and feedback that they're sharing, and may not feel as much trust or confidence that these responses won't get back to their organization. We do find that those that prefer not to answer in their demographics are experiencing increased stress, higher stress and burnout than those that do end up identifying in the demographics. If you see this term missing here, that just simply means that there are organizations who maybe chose not to include these particular demographics. Again, it's completely up to the organizations with whom we survey what their final survey actually looks like, apart from including the Mini-Z burnout assessment. Looking at race on the right-hand side here, majority of the sample, almost 65%, are from individuals who identified as white or Caucasian. This is then followed by those that preferred not to answer. And then we have about 9% of individuals who identified as Asian or Pacific Islander. And then lastly, our last 2 demographics for today are going to be role type as well as years post-training. Over on our role type, the majority of our sample are physicians, as we might expect. So 65% of our sample are physicians. This is followed by 15% who were NPs, and then 7% who are identified as physician assistants. And we do have some breakouts in our full report across role type and some differences we see across role type. And we do include other APPs as well, although that's a smaller portion also in the data. And then lastly, years post-training. This has been a really important demographic for us to review, especially in the last 2 years. And we have been noticing differences in the results based on years post-training. So you'll see that about a quarter, those that are in green there, are respondents who are more than 20 years post-training. Something for us to keep in mind, particularly when we look at work intentions or career intentions. Are these individuals who are perhaps retiring and have planned retirements, or are these individuals who are maybe retiring early? Of another 20% of our sample, about a fifth are 1 to 5 years post-training, and there's been some interesting stuff emerging from the younger physicians as well, which I'll talk about later on. And then finally, our specialties. We do survey a variety of specialties, but you'll see that our sample is predominantly represented by primary care. So we have about 19%, almost 20% of our sample that is from family medicine, 9% that's from pediatrics, 8% internal medicine, and then 7% OB. So again, highly focused in primary care for what we're looking at today. Okay, so that's going to lead me into some of our key findings that we had for our benchmark this year. And before I dive into those findings, I just want to level set on the Mini-Z for those who may not be familiar with how the Mini-Z is scored. The mini Z is 10 questions long. There is a composite score that essentially scores all 10 of those questions. And then we have 2 subscales. One subscale is scored across 5 questions. We refer to this as the supportive work environment subscale. And this is really what we think about as the culture subscale. This is where the single item burnout question sits. It's where the job satisfaction question sits, alignment with clinical leaders. So this is really our culture subscale. And our subscale 2 is our practice efficiency subscale. Here you're seeing it referred to as reasonable work pace and manageable EMR stress. This is where questions around documentation time, time on the EMR outside of work, as well as EMR frustration sit. And this scoring mechanism is really helpful for organizations that use it because we can hone in pretty quickly to see, are they having more issues in the practice efficiency domain or more issues in the culture domain, and kind of focus some of those interventions in the next 90 days post-survey. So that's going to lead me into what we're seeing in our national benchmarking data over time. And just to orient you, what you're seeing in the light purple is our most recent benchmark. That's 11,000 respondents, almost 11,000 respondents in our 2020 through 2021 benchmark. In the dark purple is our previous benchmark the year before, which was 2019 and 2020. And then all the way in blue on the right-hand side is our 2017 through 2018 benchmark. And so what you're seeing here is that from our very first benchmark, our 2017 through 2018 benchmark, up until last year's benchmark, we did see an increase. We went from 30.6 overall composite score to 31.1. That has decreased slightly in this year's benchmark down to 30.8. Those changes were statistically significant and not unusual for us to see given the pandemic that we were in. We were actually surprised that there wasn't even more of a decrease. And again, the higher the score, the better. The higher the score here, the less burnout, the more job satisfaction, more value alignment with clinical leaders. So higher scores are good. And that green line you're seeing across the top is what we consider our joy target, which is really just a stretch goal for organizations to reach towards. If we look at subscale 1, we are seeing a similar trend in had a slight decrease this year. From last year, we went from a 17.6 overall score on subscale 1 to a 17.3 this year. That those changes were statistically significant as well. And then all the way on the right is our subscale 2, our practice efficiency subscale. There was actually no change in this over time. It stayed at a 13.5 from last year to this year. And this has been really interesting for us to watch because pre-COVID, I would say the majority of groups that we worked with had major issues in practice efficiency. And obviously overall, the score for practice efficiency is lower than that subscale 1. But we are starting to see, as evidenced by these data, as well as just anecdotally from our individual reports with health systems, that subscale 1 is starting to decrease. And there are a lot more culture issues that we believe are associated with kind of the reset after COVID. How is leadership relating to their organization? How transparent are they being? And that's starting to emerge as an area for us to focus a little bit more on this year as well. So that's going to bring me into a few of our single items from the mini-Z. And I'm first going to talk about overall job satisfaction. This is a simple question. It asks respondents how satisfied they are overall with their job. Overall, 72% of respondents in our sample were satisfied with their current job. This was a 4% decrease from the previous benchmark, and it was the first year that we saw a decrease in overall job satisfaction. Job satisfaction has traditionally remained pretty steady across time, but we are starting to see a decrease. And in the first quarter of this year, in 2022, that decrease is becoming more apparent as well year over year for groups that survey annually. Job satisfaction was lowest, 70% in respondents that were 6 to 10 years post-training, which I will talk about a little bit later as well. And it was lowest in our oncology respondents. Our oncology respondents had a 63% job satisfaction. That brings me into job stress, asking respondents, they say, I feel a great deal of stress because of my job. How strongly do they agree with that? Overall, 52% of respondents were experiencing a great deal of stress. This is also a 4% increase from our previous benchmark. Job stress was higher in females, almost 11% higher in our female respondents than our male respondents. This was particularly true in females that were 6 to 10 years post-training. And it was also, again, job stress was highest in our oncology respondents at 64% and family medicine at 61%. And then lastly, of the single items is our burnout, the single item burnout question. And this asks respondents based on their own definition of burnout to choose how burnt out they feel. And we consider burnout anything that you see in that yellow, orange, or red. So these are respondents who are either just beginning to feel burned out in yellow, to experiencing symptoms that won't go away in orange, all the way to those in red who are completely burned out and maybe at a point where they need to seek additional help. Overall, in our national benchmark for this year, 51% of respondents were experiencing burnout. This is again a 4% increase in burnout from the previous benchmark. So something with that 4%, we see a 4% increase in stress as well as a 4% increase in overall burnout. Burnout was highest in respondents 6 to 10 years post-training. This sat at about 58%. And it was also highest in physician assistants at 56%, compared to our nurse practitioners at 55% and our physicians at 50%. A quick note on those that are 6 to 10 years post-training, since I alluded to this in an earlier slide, this is a trend that we are also keeping an eye on and is not necessarily surprising to groups that we work with, but particularly in those female respondents who are 6 to 10 years post-training. Hypothesis here is that these are individuals who are kind of mid-career, growing their careers, but have also had to take on an enormous burden throughout the pandemic in things like childcare and adjusting to different schools and schooling from home, and having to deal with that kind of stress in addition to growing their careers. And so organizations who have been able to talk and hold focus groups for those respondents, females 6 to 10 years post-training, the number one thing they're hearing is around scheduling and having some flexibility with scheduling. And of course, that is not always possible at every organization and within every specialty, but some organizations have been able to be pretty creative in how they offer flexibility. And it's not always that, hey, I want to work whenever I want to work. Sometimes, you know, someone might say, I'd rather take a Saturday shift so that I can have Wednesdays off because there's something going on with my kids. They are schooling from home on Wednesdays. So certainly a place to think about or dig within your organization if you're hearing that as well. And then lastly to note here is that burnout, again, and this is a trend we're seeing, oncology, almost 70% of oncology respondents were burnt out. This was followed by family medicine at 59% and critical care medicine at 57%. And that's going to bring me to our time on EHR. And this is a metric that we keep close eye on, especially in primary care. And we know that these numbers look pretty stark for family medicine in primary care, even pre-pandemic. But this question asks respondents whether the time that they spend on the EHR outside of normal scheduled work hours, including work done at home, is excessive or not. And overall, in our benchmark, 46% of respondents note that their time on the EHR outside of normal scheduled work hours is excessive or moderately high. This is highest in our physician respondents, unsurprisingly, at 51%. Also in oncology at 64% and family medicine at 61%. 30% of our respondents did note that they spend more than 6 hours per week, almost a full workday per week on the EHR outside of normal scheduled work time. And on average, respondents spend 4.3 hours outside of normal work time, which is 1% greater than the previous benchmark. This is just another way for us to look at time spent. Right now, we're looking at a distribution of full-time versus part-time respondents in our sample. This is a subjective question that asks respondents to rate how much time they spend within a week doing direct patient care, indirect patient care, administrative tasks, teaching if that's applicable to them, research if that's applicable to them, and then other hours, and we total that up. We know from research a couple of things. Once we reach a 55-hour work week, burnout tends to exponentially increase. This is largely due in the research to lack of sleep, but that 55-hour mark seems to be a threshold for organizations to keep an eye on. Additionally, a question we often get is, because these are subjective ratings of time spent, how accurate are they? Some organizations feel that perhaps respondents are over-reporting subjectively how much time they're spending in the EMR. But we're actually finding in some research that is happening and some research that we're doing, given EHR data and being able to actually pull EHR data and time spent within the EHR and understanding what's happening within the clinical environment better, that these are often underreported. So the subjective ratings that you're seeing here are probably an underreporting of how much time these respondents are actually spending on these activities throughout the week. For full-time respondents, the work week was an average of 56.6 hours. For our part-time respondents, that was 43.3. Part-time is sometimes a little hard to decipher because some organizations define part-time as anything under 40 hours worked per week. Some define it as much less. So it's really up to those organizations to understand when they see those distributions between part-time and full-time, how close is that to their actual definition of part-time? Is it true that you could be considered part-time and still working 38 hours, or is part-time, you're supposed to be working 32 hours and you're working 43, and so you have a lot of part-time people that are actually working full-time hours. So that varies by organization. The other thing we like to take a look at is the ratio between direct patient care to the time spent on indirect patient care and administrative tasks. So that's comparing what you're seeing in green compared to what you'd see if you combined the yellow and the purple that you're seeing here. And in most organizations, we're finding almost a 1-to-1 ratio, just slightly under a 1-to-1 ratio, where respondents are spending almost as much time on indirect patient care and administrative tasks as they are spending on direct patient care, calling into question kind of what are the workflows like, why is that happening? Is it because of staffing issues, which I know all organizations are experiencing right now? Are there things within the workflow, sort of low-hanging fruit opportunities to streamline the workflow where work can be shared among clinical support staff like our nursing staff as well as our medical assistants, and how can the administrative team help support some of that work as well? Some of this is regulatory, and of course, organizations are working on that as well. This is a look at the same question just by role type. So I'll briefly note this in our physicians. They had an average of a 55.7 hour work week. This was next lowest in our nurse practitioners at 54.7, followed by our physician assistants with a 50-hour work week. And then those other APPs was about 40, almost 49 hours per week. And this leads me into the value question. This is a relatively new question that we've been implementing, well, maybe not new anymore, but we started to implement this question at the onset of the COVID-19 pandemic, where we simply ask individuals how valued they feel by their organization. And we know from research that we've done and have been able to publish that individuals who feel valued by their organization are also less likely, almost 60% lower odds of experiencing burnout, self-reported anxiety or depression, and likelihood to leave their organization. So in this benchmark, in our benchmark right now, we're seeing that just under 50% of individuals feel valued by their organization. We define that as those who indicate that they feel valued either moderately or to a great extent. And a lot of times this can serve as kind of a drop the mic, for lack of a better term, a drop the mic moment for organizations doing survey work, to see that so many people may not feel valued by the organization. But we really like to reframe this as a really good opportunity for organizations to find some low-hanging fruit strategies to help people feel valued. And oftentimes, these are really basic things that I think maybe get lost in the sweep of getting back to normal, whatever normal looks like. But in the early days of COVID, a lot of organizations were focused on meeting kind of the basic needs of their employees, so making sure they had healthy food available, which we found in our survey data to be a key indicator, particularly for our trainees, and just thinking about how to recognize the work of so many people who are sacrificing a lot to stay in healthcare right now. And so this can often be an area that groups can do now, can work on now. And in a lot of our surveys, we see people say, the pizza was nice, but I just really want a verbal or written acknowledgement from my immediate supervisor that I'm doing a good job and that it's hard to show up every day. Thank you for showing up today. To have executive leaders rounding as they did, as a lot of them did in the early days of COVID. So while this might be a drop the mic moment for organizations, we really think there's a lot of low-hanging fruit opportunities for organizations to help make people feel valued through very basic, simple things like acknowledging the contributions they're making to an organization. And we've seen in the research the return that can have in lowering burnout and protecting people from self-reported anxiety, depression, and likelihood to leave. And that brings me to the likelihood to leave question, which is one that is become of interest to us, always has been, certainly in the last year and a half. But this is a key question that most organizations are now asking. And this question asks respondents, what is the likelihood that they will leave their organization in the next 2 years? And we know from research that approximately 30% of individuals who say that they will leave do leave. They act on that. So this can be an early indicator of either what will be happening in the next year or two, and also may help organizations keep those individuals based on the other results within the survey. Overall, in our benchmark this year, 37% of respondents noted an intention to leave, and we define that as moderately likely or definitely. And this was a 3% increase from the previous benchmark at 34%. The likelihood to leave was highest in those that were 20 plus years post-training at 42%. Probably not surprising, these are individuals who are retiring, although given staffing shortages right now, people leaving medicine, there are a lot of organizations thinking about how to retain these more seasoned individuals. Can they drop to part-time but still be working? How can we engage them in mentoring opportunities for the younger physicians who are just kind of entering the field? Because this is then followed by 36% of those that are 1 to 5 years post-training who are planning to leave their organization in the next 2 years, and then the 35% of those that are 6 to 10 years post-training. We've been talking a lot with organizations about that 1 to 5 years and how shocking that can sometimes feel when you have brand new physicians who are intending to leave in the next 2 years, and why is that happening? Based on some of the qualitative data that we've seen in our data, a couple of things come to mind. One reason that we believe these individuals may be wanting to leave their organization is that the onboarding. What has happened with onboarding new physicians, acclimating them to the culture of the organization, and really making them feel like they're a part of something, making them feel valued when they first join your organization. Oftentimes, a lot of those onboarding activities have kind of gone to the wayside as people have been so focused on dealing with COVID, of course, and also resetting from COVID and dealing with staffing shortages, that it's been missed that you are going to be onboarding a lot of new physicians who still need to be acclimated to your organization and your organizational culture. And this makes us think about, and as I was saying, on how to leverage those that are more seasoned, those 20 plus years, those 11 to 15 years post-training. How can they serve as mentors for these new physicians? How can they be stewards of the organization to help bring new people in? And then, of course, there is the sense or idea that, I think some residents leave residency thinking that going into being an attending may be less stressful than residency, but they are entering this time and entering organizations during a pandemic. And so there may be some misalignment on expectations there, and that may be driving some of this. But this is an indicator we'll be keeping a very close eye on over the next year. And then this leads me to one of my last slides before I talk a bit about what organizations have been doing in response to their data. And this is our qualitative findings. We have one question in the survey that asks individuals, tell us more about your stressors and what we can do to prevent them from being stressors. And these are kind of the 5 overarching most common themes that we're seeing. Lack of adequate support staff. This is a hard one to solve because a lot of support staff are leaving organizations or leaving medicine altogether. So we obviously know that hiring new support staff is very, very difficult for organizations right now. But I think this is an opportunity for organizations to think about how the current support staff that you have, how do you keep them at your organization and make sure they feel valued also? And how can we train them up to make sure that they are sort of working at the top of their license, for lack of a better term, and incorporate it into the day-to-day operations of the practice, and really empowering them to take some of that work on. Lack of support or transparency from leadership. This has been a big one, especially in the last 6 months to a year. Individuals feeling like there was a ton of transparency at the beginning of COVID, that leaders were very transparent, very open, sending out letters, newsletters, town halls throughout the early days of COVID, and kind of feeling like there was this all hands on deck approach and that everyone was in the loop. And that seems to have subsided in a lot of organizations. So there are a lot of folks feeling like information is not being shared with them effectively, that they don't know what's happening. from a leadership lens. They don't know what's happening within their organization, and that's making them feel uncomfortable and, again, not valued by the people with whom they work. Too many administrative tasks. This is true pre-COVID. It continues to be true during COVID, and I will likely be true post-COVID, and can really help organizations hone in on pilot interventions they can do within certain specialties. EHRs being ineffective, again, very common pre-COVID, continues to be an issue for a lot of organizations. And then just personal stress. And this has come out a lot about just feeling really fatigued by dealing with COVID for 2 years, and dealing with any family or personal stress that they might have going on. So just a quick summary of what I just went through for all of us. Job satisfaction is decreasing. That was a 4% decrease year over year, even though this was the first year we were seeing a decrease. Burnout is increasing, 4% increase as well. We believe issues remain at the system level. This hasn't changed for us. We think that most organizations need to focus on the system and fixing the system, not fixing the people. That value and making people feel valued is a low-hanging fruit opportunity to really help prevent people from leaving, because that intent to leave is increasing. Particularly those 6 to 10 years post-training are likely an area to focus on within your organization, especially with those female respondents that are 6 to 10 years post-training, and that systems need to be strategic. This isn't an overnight solution. Data can help equip you in that strategy, and we, of course, are there to help with that as well. And that just leads me into my few final slides about some action steps and lessons learned from organizations who are measuring, who did measure, have measured, have been able to develop interventions in support of what they see in their data. First and foremost, and I know I've been saying this throughout, but making measurement a system standard is really important for organizations. As we like to say, you can't change what you don't measure. And so having data, making measurement a priority, and being able to vocalize the why, tell people why you are measuring, and then to follow through in sharing what you've learned and what you're going to do next has really helped organizations be successful in this work. Nobody has all the answers. We certainly humbly do not have all the answers. We are learning right alongside all of you, all of the organizations with whom we work, but we do believe that data can drive us in the right direction. Organizations that share their data across their organization and are transparent in what they're finding often tend to have higher response rates the next year, and people who are willing to come to the table and have conversations about what to fix and how to fix it. Looking for pebbles in your shoe, we know that, again, these solutions won't happen overnight, but there usually are some, like I said, low-hanging fruit, pebbles in your shoe opportunities that you can address very quickly to get some quick wins. Continue to get buy-in from those within your organization that you are at least paying attention and are finding those quick wins, so that you can focus on longer-term strategic initiatives that may take more resourcing, more buy-in, and just a longer time period to implement. Peer support has also been really important throughout the pandemic. We have seen most organizations with whom we work have at least some kind of informal peer support program, although most organizations are starting to formalize this. And physicians having a peer support and being able to lean into colleagues who are having similar experiences has seemed to be a protective factor for them as well, and has been a really important tool for organizations to leverage. And then lastly, and I've noted this already, is really transparent communication and having leaders who are willing to be transparent with what's happening within the organization and how that's going to be having an impact on their physicians and their care teams. At the AMA, we have developed a Joy in Medicine Health System Recognition Program, and I wanted to note this today because this is really a strategic roadmap for systems change for organizations. So as I noted at the beginning of the presentation, we don't just want to give you data for data's sake. We want to give you data and then also equip you with what's next. And so the Joy in Medicine Recognition Program, while it is a recognition program, it does have sort of that award bent. We want to hopefully propel organizations to invest in this work. The actual program itself provides an incremental roadmap, sequential steps for long-term solutions. Assessment is foundational to that, and I'm happy to answer questions you have about that, but all organizations that come into the program do need to be assessing using a validated tool. It doesn't have to be through the AMA. although of course we'd be happy to work with you, but it could be Maslow, it could be Mayo's Wellbeing Index or the Professional Fulfillment Index with Stanford, but we do require that organizations are measuring systematically using a validated tool. We had 44 organizations recognized in 2021, and we recently just closed applications for our 2022 cycle, and we'll be sharing announcements on which organizations have received recognition this year in 2022, later this year, likely in the late summer, early fall. It is a 2-year rolling application, so if you received recognition in 2021, you did not need to reapply this year, so the majority of the groups that applied in 2022 were new organizations, which was exciting for us. Just a quick note on the roadmap. As I said, these are incremental steps. It is evidence-based. We have 3 different levels to help guide groups through. We have a bronze, silver, and a gold level, and we hope that organizations will be able to come in at bronze and be able to work their way through silver and gold. We think this is a long-term strategy, so we expect it will take years for groups to go from a bronze to a gold. This is not meant to be a check-the-box initiative, but is really designed around 6 pillars to help support making wellness and well-being really a core institutional value that is resourced and has buy-in from an executive level. And so that's going to bring me to the end of today's conversation. Just a quick note, if you are interested in doing an organizational assessment with the AMA, as I shared at the beginning, this is mission work for us. There's no cost to doing it. We would be happy to work with you. And if you are interested, you can email us at practice.transformation@ama-assn.org, and we'd be happy to have a conversation with you. So with that, I'm going to turn things over to Brittany and happy to answer any questions you have.
Thank you so much, Kira, for that really insightful and informative presentation on such a meaningful topic. I just want to remind participants to go ahead and input their questions in the Q&A box. We already have several in the queue, so I'm just going to go ahead and jump in. So Kira, this first question is around resources and tools that you might have available. This participant would like to know if you have an organizational chart to guide the launching of a well-being program.
Yeah, so we have a couple of tools available within the AMA. Our Steps Forward website, our modules, I believe has a module around establishing kind of a wellness committee with a number of resources attached to that from the literature. And we'd be happy to share with those links after today, or make sure they're deployed after the end of the webinar. And then even within the Joint Medicine Recognition Program, there are a few linked resources in there. And one thing we are building right now, this is sort of inside scoop, we are working on building a more enhanced roadmap for the recognition program that will include samples from organizations who have received recognition. So being able to share sample well-being charters, sample committee structures, because it can look so different from organization to organization. So that's something we're hoping to launch this summer, so that organizations can really not just use the roadmap as a guide, but actually dive into sort of sample tools that can support them in that work. And this is also a good time to mention that as part of the recognition program and our overall efforts in supporting health systems in this work, one thing we are hoping to build out is to have something like a learning network. How can we pair up groups that come in through the recognition program to help support one another and share learnings? Because again, as I said, we don't have all the answers at the AMA. We're learning right alongside you, and there's a lot of power in convening health systems and the work that they're doing. And a lot of health systems don't talk to one another. And so how can AMA serve as that kind of neutral convener? And that may include something like pairing a gold group with a bronze group to talk about, specifically around efficiency of practice. How are you leveraging EHR data to understand the clinical environment? Maybe it's pairing a bronze group with someone who's not even at bronze yet, but is just getting started and really just needs some guidance on what happens next in the short term. So that's all brewing and things that we're hoping to build out in our own programs, but specifically about building a wellness committee. We do have some resources through Steps Forward, as well as within the Joint Medicine Recognition Program, and we'll make sure that those get distributed after today.
Thank you, Kira. In relation to the Joint Medicine Recognition Program, this participant asked if there are any basic organizational criteria for surveying or applying for the Joint Medicine Recognition Program.
Yeah, great question. There are a couple. There are a few. There are three. The first is that your organization has at least 100 physicians or APPs. This is a health system recognition program, so it is not yet designed or intended for very, very small practices. So we do ask that organizations that apply have at least 100 physicians or APPs that are employed. And we are learning as we go. There are obviously so many different types of organizations in healthcare. So if you have a question about whether you qualify with that specific eligibility criteria, you can reach out to us and we'd be happy to talk to you. The second is that you have signed our CHARM Charter. The CHARM Charter came from the Collaborative on Healing and Renewal in Medicine, I think 2017, 2018. And this is really a set of principles that organizations are signing on to use as a guidepost for their work around well-being. All it requires is you to fill out a form with your information, and you're essentially agreeing that you will use these principles to guide your work with your organization. So that's the second eligibility criteria. And the third is that you have assessed burnout using a validated tool at least once within the last 3 years. And as I was noting earlier, assessment is foundational to the recognition program. So groups must have done that at least once in the last 3 years, measured burnout using one of the validated tools. And there are 4 that we've included on our website, including the mini-Z and the single item mini-Z.
Thank you, Kira. So for this next question, it looks like this participant is coming from a large surgical society of 40,000 members. They would like to know what type of program could potentially help them reduce burnout from the 51% rate that you discussed today.
Yeah, I mean, that's a loaded question. I don't know that I'm going to have the one answer for being a surgical society. And I will admit most of the work that we do is with the health systems and the practices themselves, less with the societies, although I'd be happy to have a conversation with you. I think this depends on what your data might tell you and what you might know about what's happening within surgery specifically. Surgery certainly has unique needs, unique drivers of stress. And so it's hard for me to give a one-size-fits-all answer. But I do think that there's something to be said about culture and leadership. And I know I alluded to this throughout the presentation, but I think we're seeing a lot of organizations struggle with culture right now and struggle with how leaders are showing up and the messaging that they're giving to their physicians and the people who are sacrificing so much that it sort of feels like a rip current. COVID has felt like a rip current that everybody was all hands on deck in the early days of COVID. We actually saw a lot of people doing quite well in the first 6 months of COVID and that we were surveying, to then feel like, okay, we're opening up, we're going back to normal, but operations weren't reset, that we are entering a new world. But it feels like perhaps the messaging and leadership that's part of that new world is still kind of stuck in the pre-COVID times. So that's where I would look first, is really what is culture like, and how are you, like you as a society, building that culture up, and what kinds of resources are available for leaders, your members who might be leaders. And then certainly there are workflow issues that we see specifically in surgery, and how support staff are trained to actually help surgeons, both in the surgical room as well as within their ambulatory practices. So I would say, look, there's not a one-size-fits-all answer. And again, I'd certainly look at data to help drive that. But I would look to culture first, since we're seeing that come out as such a driver in the last 6 months to a year. What kind of messages are being sent? How can you make people feel valued? Those are the low-hanging fruit opportunities.
Thank you, Kira. This next participant would like to know if you have any insight on organizational analysis for smaller practices.
Not a ton. I would say this is something that we don't have a lot of information on. Most of the organizations that we do work with from an assessment perspective are quite large. So looking at, hundreds of physicians or APPs. We are starting to do work with federally qualified health centers and community health centers, which has been really interesting for us. And we have seen that smaller practices, particularly these FQHCs and the community health centers, are faring a lot better than our larger systems. And it seems like there is more localized control around the culture. There is more control over the workflows and the resetting post-COVID. But there are a few groups that are coming to mind, and we haven't analyzed these data sort of systematically, but a few groups recently who have surveyed a second time during COVID, and we've actually seen their mini Z-scores increase, their job satisfaction increase, their burnout scores decrease, which is not as we've seen in a lot of the larger health systems. And so I think there's something there for us to learn. We haven't really done a deep dive on that yet. But one thing we are hoping to build out in our data lab in the coming years is to be able to tag our data based on the type of organization. Right now, everything in the benchmark kind of comes in all together. And so we haven't been able to tag it to really look at, okay, how are academic medical centers compared to community hospitals, compared to FQHCs, and are there differences? To know, we assume that there are, we just haven't been able to analyze the data that year, and that's something we're looking to build out in our work this year. So great question. Don't have an amazing answer for that, but I hope that gives you some insight into what we're seeing in those community health centers.
Thank you, Kira. This next question, it relates to things that might be down the pipeline. This participant you mentioned that the organizational biopsy is targeted to physicians and APPs. What other roles are you hoping to expand to in the coming years?
Great question, and one that we are actively exploring. And as I shared earlier during our COVID survey work, that COVID survey was available to all role types, clinical, non-clinical. It went to all organizations, and most organizations chose to survey the entire organization. And there were downsides to that because a lot of times, as much as it was good to be measuring everyone and kind of figuring out where everybody was at during that time, not all organizations then had the resources to respond to that. So they would then ultimately end up focusing on their physicians, their APPs, their nursing, which would leave a lot of people out who were kind of saying, hey, we gave you our responses, we told you that we're dealing with this. They didn't necessarily have the capacity to respond to that. So that's always something we keep in mind when doing any survey and determining who that's going to go to, how much capacity does an organization have to respond. And we often believe it's better to start slower and then build over time. For us and the organizational biopsy, we are exploring right now, we're actually piloting a nurse survey around the org biopsy to really support organizations in measuring nurse burnout, in particular drivers of burnout within the nursing staff. This is partly because in our COVID research, nurses had much higher rates of burnout, much higher rates of stress than any other role type. We know that nursing shortages are wide spanning right now across the country. And so we're just starting to pilot this. It's certainly not available to everyone right now, but I do think as we grow our work this year, we'll open it up for organizational assessments for nursing staff with intentions to continue to expand that over the next 2 years into other clinical support staff as well.
That's great. Thank you, Kira. So this final question, we have about 6 more minutes, so I think we can probably get to 2 more questions. This participant indicated that transparency from leadership cannot be forced and would like to know if you have any strategies to allow this to happen a bit more organically without it being a difficult conversation with leadership.
Yeah, that's a great question. I think that within a lot of organizations we work with, there's at least one leader that has sort of this innate leadership ability and able to be transparent and communicative and to model that behavior. A lot of times that may be a chief wellness officer or a director of well-being who is already modeling that behavior and being able to show that it might be having an impact. Interesting story, and this is not a direct answer to your question, but within certain departments, you may know of leaders who are doing a really good job at kind of modeling that transparent, supportive behavior and messaging. So we had a group where their one of their chairs of family medicine did this so well. He was sending out weekly communications about how he was doing, sharing that he himself was struggling, and that if someone was feeling a certain way, that, hey, you're not alone. It was very brief, like a paragraph or two. But we actually saw in family medicine that value increased over time, and we were measuring almost monthly for them. We were doing a pulse survey. So value is increasing in family medicine. They weren't doing any practice efficiency interventions because we were in the middle of COVID. So the thing they had focused on was really just having this chair send out a weekly email about how he was doing and the struggles he was having in his life and adjusting to this COVID world. And we saw value increase, and there were actually a lot of people in those comments who would talk about how refreshing it was to know that this kind of stoic leader, as they had come to know him, was willing to be vulnerable with them. And of course, again, as you note, that it can't be forced. It has to happen organically. But we were able to show through data that value had increased, that burnout was decreasing, particularly in family medicine. And then we had peers from a couple of other departments, and I forget exactly which departments they were, start to do the exact same thing. And the messaging wasn't exactly the same. Some of them were a little bit more vulnerable than even he was, some were less. But just to have a consistent message coming from a leader to say, hey, I've been thinking of you, there was that modeling happening, and then we were able to support with data that there was actually a change we could see based on that behavior. So I don't mean to suggest that all leaders are going to be immediately transparent, that it will all be organic. It won't be, and that's a huge challenge organizations have. But when we can have leaders who are willing to model that and then support that with data and the change that we're seeing, I think that's a good step in the right direction to at least start.
Thanks, Kira. That's a great story and great example. I am going to wrap us with one final question on the topic of joy in medicine. As an organization applying for bronze category next year, do you have any advice or action items that can best prepare this group?
If you're not assessing, I would recommend at least thinking about doing an organizational assessment. And as I've noted, I would be happy to talk with you about that and how we might be able to support your organization in that assessment. If you have assessed, I would say if you haven't yet checked out the criteria for the bronze level, definitely do that. And if you have questions about those criteria and kind of how to build on those, please reach out to us, and we'd be happy to have a one-on-one discussion with you.
Wonderful. We are just about at time. So Kira, I want to thank you so much for your time and your commitment to this important work. To wrap, I just have a few concluding slides that I want to go through. We want to remind the audience to check out the suggested content located in the resources widget of your console. For any additional resources to support your physicians and staff, please visit the American Medical Association website. Next slide, please. Thanks. We hope you're able to register and join us for the next AMA Steps Forward webinar on protecting mental health in disasters, COVID-19 and beyond, which will take place Wednesday, May 11th at 12 p.m. Central Time. Again, you can use that resource widget to register today. Next slide. Oh, we could go back one, yeah. Thank you. We would like to briefly announce a new Steps Forward initiative, the Recognition of Participation Certificate, which provides recognition to physicians, care teams, and healthcare leaders who've participated in 3 or more activities as part of the AMA Steps Forward Innovation Academy, including these webinars. Please follow the link in the chat for further information on this program. And then finally, if you would like to receive updates concerning AMA Steps Forward programming, please email that Steps Forward email, stepsforward@ama-assn.org. Thank you all again for your time today. To our participants, we hope to see you again soon.